And while you're getting to your seats, for those of you that are already at your seats, may I please ask a favor? You will see one of these in your folders. It is really important. It is our survey and evaluation for all of this. Like I said on Friday night, about 2 weeks from now, we start planning for next year. And so your feedback's really important. So if you wouldn't mind, while I'm talking, I will not be offended if you get this out and do it before you leave. Let me give you just 30 seconds of protected time right now to do it. While I explain what this is my favorite part of the weekend, and this is the lightning talk weekend, or lightning talk section. Let me explain to you what a lightning talk is. It is a TED-style talk, and the reason that we're very careful to say TED-style is because we, unlike TED, do not program it. We don't give you a structure. But what we do ask is that you bring some sort of policy or public health issue as it relates to the theme of the weekend and a personal story to it. And so this is the most exciting part of the weekend because we get to see how all of this becomes cohesive and how all that you learn here is actually applied. It is my great pleasure to introduce our first person, Ruben Azocar. He's the current Vice President for Perioperative Services at Beth Israel, and he also graduated from my program, and we were both taught by Rick, as you guys were also earlier today, in 2016. He's from Venezuela, and he is going to talk to you today about suicide, a public and mental health problem. And I had the fortune of hearing this before you guys did, and I'm excited to listen to what you have to say. Each of these talks is 10 minutes, so take a deep breath, get ready, and let's go. Ruben.
Well, good afternoon. My name is Ruben Azocar, and I will be talking to you about suicide as a public and mental health problem. So the only disclosure I have before I start the talk itself, I'm on the board of directors of the Samaritans, which is an organization that devotes itself to prevention of suicide and also provide support to those who have lost a loved one to suicide. So it was a Friday night in May, and I was a fellow in Cook County Hospital doing a surgical critical care fellowship. And it was a horrible night, I remember, and probably went to bed around 4:30 in the morning. But around 6 in the morning, I got a page from my wife. You know, there were no cell phones, right? This is 1997 or anything. And the page had our home number and 911. And so I called her immediately and she said, "You need to come home. Something happened back in Venezuela." I was lucky that somebody was able to cover me. And I came home to know that my brother had died by suicide that night using a firearm. So why is this a public health problem? So suicide is the 12th cause of death in the United States. There are years that it's been as low as the 10th one. And what does it mean, right? And you know, most of you, if you train here, I hope that you went to see the Red Sox at Fenway Park. And when Fenway Park is full, there's about 35,000 people there. Well, 15 more people than that died every year of suicide in the States. So 50,000 people or so die of suicide every year in this country. And what is a mental health problem? Because about 46, and this is probably underreported, 46% of the people who die by suicide, you can connect that they have a mental health issue. A lot of times depression, anxiety, and so forth, and again, probably underreported because a lot of times suicide happens without anybody knowing what's going through this person's life. So why do I get involved on this and want to talk to you about suicide today? I'm using the little pyramid here. And, one, because suicide affects the young. And I have a personal connection with the loss of my brother, Ricardo. So Ricardo had turned 18 on Tuesday, and then he died by suicide that Friday. And suicide is the second cause of death between ages of 14 and 25 in this country. If you are on the LGBT plus community, that's even higher. Also, millennials have a very high risk of suicide. Why also? BIPOC, and I have Latino heritage, and we are Hispanic Heritage Month this month, and there is that connection of being from Venezuela, being Hispanic or Latino, and we have seen since 2011 to 2021 a 40% increase of suicide among Hispanics. If you are Hispanic, there's about 50% less chances that you have good access to a cultural sensitive or access at all to mental health. And about 11% of the Hispanic high school students consider suicide. And what else? In my profession, I'm a physician, an anesthesiologist, and a critical care specialist. Every year, 200 to 300 physicians commit suicide. If you are a male physician, you have 1.2 times more likely to die by suicide than the regular population. If you're a female physician, that goes up to 2.3. So high risk. Medical students as well. There was a few years in New York, several medical students died by suicide, and consider about 11% of them consider suicide during the years of med school. Anesthesiologists were also at a high risk. Unknown at times if it's related to our access to lethal medications, but we are up there on that group. And that comes with a second story. Not dissimilar, but this time turn the clock or the calendar to 2017, and I'm the chair of an anesthesiology department here in town. I'm gonna get the text that one of our faculty members didn't show up to her cases that morning. And this will connect to the next slides, which is, the 3 S's, especially with the first S, which is the signs of suicide. So, knowing a little bit of what the signs of suicide might be in the people that's surrounding you will be important. Is somebody talking and even joking about death or suicide or dying? Are they changing their weight or, their appearance, and all of a sudden, a little disabled? Their performance is not the same. They're losing interest in things that they do. Do they have extreme mood swings? And they can be extreme euphoria or happiness, or direct statements like, I'm tired of it, a burden, or nobody will miss me if I'm not around. Sleeping too much, having impulsive behaviors, or seeking lethal means, giving away possessions, and withdrawing from friends. But it's also important to know the risk. Those who had a prior history of suicide or suicide in their family, those who had suffered sexual, domestic, verbal, or child abuse trauma, if they had a substantial loss, relations, social, work, financial loss, facing oppression and injustice, that's racism or sexism, substance abuse, or any other addiction might be linked to that. Lack of healthcare access. I talk about the LGBT community having a high risk as well, and homelessness. So if you put those things together, in our case of our faculty member, I was not in retrospect surprised. She was going to struggle. And weeks before, I had reports from the residents saying that she wasn't the same in the operating room with them, that she was very reactive. And we were going to talk to her about it. But it was a little late, because by the time the week we were going to talk to her, she died by suicide that Sunday on Mother's Day. The second S I want to talk to you, I think is a very important one, which is the stigma. And going back to my brother, I remember when I arrived to the funeral home from Chicago to Caracas, my father was standing out there, and the first thing he came out of his mouth to say, this was a car accident. Don't tell anyone. Because, he had the stigma of mental health. Dying by suicide has social, and at least in the Hispanic community at times, very heavy religion implications. And things that you can do about is one that you might notice that I haven't said committed suicide, because committed has the implication of a sin or a crime. I have said die by suicide, lost somebody by suicide, not committed. And I think the other thing that I want to try to inspire you to is to learn and talk more about it. In the past, people say, don't talk about suicide. Don't discuss it with somebody who might have the sign or the risk, because they might put the idea on their mind. It's all contrary. Data shows that speaking about it, learning more about it, and being advocates is important. And support. So September is Suicide Prevention Month. There are suicide prevention organizations, but I think the most important number you might learn is 988, which is the National Suicide Hotline. And somebody can call, not there only because we're at the moment about thinking by commit suicide, in the next minute. But if somebody has a struggle, there is always 24/7 somebody that can speak to, listen to, and there are many languages, including Spanish. Support for those left behind is also important. It's very hard, and it's very hard to be here today. It's the first time I'm giving a lecture about this. Learn and talk more about mental health and suicide. We know mental health is a huge problem in this country, and it's linked to suicide. And advocate for improvement of mental health in access, quality, and cultural sensitivity are things that we can do in our roles. So in summary, suicide is a public and mental health problem. I hope if you recognize some of the high-risk groups, but also recognize the signs, break the stigma, and provide supports. With that, thank you very much for listening, and I think we have time for some questions. And there is data of people coming to emergency departments. It went up, especially in the teenager group. And I think, that we all went through the pandemic. But imagine you're a teenager with all the problems that being a teenager has, and all of a sudden you're completely isolated from friends, school, and others. So yeah, there was a spike, and probably that's why during those years, from 12th it went to 10th. Also, trauma and other things came down, but in large was a lot of more suicide attempts during the period. I think we have time for one more question.
Yes, the bias between public perception of male versus female suicide, and that males are often more successful. Therefore, I think women have this interpretation in popular culture as getting attention.
Yeah.
And so, what sort of do you really see different sort of tactics with different communities?
Yeah, I agree more. And, it's very interesting because the suicide rate is higher in males, but the suicide attempt rate is higher in females. What happened, males tend to choose a more lethal means, most of the time firearms, than females, but females have a very a higher risk. We see it in the medical community. It's almost, it's 1.2 versus 2.3. And I agree, there might be, I think each group might have different reasons why, but, high expectations, frustrations on no progression, all things that might trigger that, that you start thinking about, ideation to, proceeding with, a suicide attempt.
Since our theme is about equity, I wonder if, as public health professionals, we can do something about the fact that, from a policy standpoint, I could go to my doctor unlimited number of times for diabetes, unlimited number of times for high but I'm limited in the number of days that I can get mental health care. And I just think that's wrong.
So I think part of this is that connection. And, if I had to say, on the Samaritans, they have changed a little bit their emphasis on prevention of the crisis moment, but having a more holistic, mental health solution to this issue.
I think we have one more question and then we can go to the next.
I wonder whether level of participation in social or political events is a sign. For instance, if someone says if Trump gets elected, I'll kill myself, or if on the other hand they say I'll work to oppose, does that kind of expression indicate anything about the attempts to continue living well as a point in time?
It cut off a little bit. I don't know.
Yeah, I'm sorry. Could you repeat that question? I think, could you use another mic? I think your mic has a lot of static. Thank you. Much better.
It's a general question about involvement in at-large political affairs of a country. For instance, how elections go. Will someone say if Trump gets elected, he or she will kill himself, or instead work harder to correct things?
You capture that question?
The political,
Advocacy? You refer to like political advocacy?
that if, like, for example, if people say, if Trump gets elected, I will kill myself.
Oh.
Is there something to that in the sense that, does that sort of stigma? Or,
I think you have to put it in the context of the person. I think sometimes we say that, I can jokingly as an anesthesiologist say, oh, if they hire this surgeon, I'll kill myself. But, I've not really meant it. I think you need to look at it in the context of somebody who starts talking jokingly, say, suicide, or I'm a burden, or, something like that. I don't think an emotional reaction to an event could be. But, if that person is having other risk factors and have a sign, you might, keep your antennas up. Yeah. Thank you.
I think you had just a quick question.
Yeah, Ruben, thank you so much for doing this topic. I wonder whether you
Are you pressing? Yeah, thank you.
Sorry.
That's okay.
Thank you very much for your presentation. I wonder whether you are aware of the studies in showing the link between the rate of suicide and religious beliefs and differences between different religious orientations.
Yeah, so if you're talking about LGBT plus, the suicide attempts on that group, especially in teenager, and especially after, a bullying event or some, traumatic event related to their sexuality, it goes really high.
But I was asking about the religious beliefs.
Religious beliefs.
Religious belief.
Yes. So are certain.
Well, I can say, I'm being Catholic, brought up in a Catholic Jesuit school, it was like suicide was a sin, right? So at least in the Hispanic population, if they are really religious, right, that the concept of suicide is a stigma, right? You don't talk about, and, have a mental health issue it's weakness as well, socially. So I think that there is a lot of stigma on, in certain groups where suicide has a religious implication that is a sin. If you die by suicide, you don't go to heaven, right? Because it's a sin, and people might feel like that, and I grew up with that idea in my mind.
Does it translate into different rates of suicide in different groups?
Yeah, probably.
Do you
Yeah,
have any statistics about this stuff?
yeah. I don't have an answer.
Thank you.
Thank you, Ruben. So imagine being diagnosed with cancer and knowing there's a cure and not being able to afford it or access it. So that is our next presenter, Eddie Cliff. And Eddie is a hematology fellow and postdoc at Brigham. And he has a focus on health policy, regulation, and access to medicines. And Eddie, you graduated MPH 2022, right?
Spot on.
Okay.
Thanks so much.
Because you're all the way down.
Vivian.
Yeah. You start right here. Please fill out your forms, your feedback forms while we're waiting. Yeah.
So I'm Eddie. I'm a heme fellow specializing in blood cancers and blood disorders and also in health policy. And I want to talk about taking pharmacoequity global, that on the theme of today's weekend, the right to health, that I think that people, wherever they are in the world, wherever they're born, wherever they live, should have a right to access medicines. And I want to focus particularly on cancer medicines. So I'll start with some good news, and that is that cancer death rates in high-income countries, you can see the UK on the left and the US on the right, are going down, and we expect them to continue to go down, and that's true whether you're a man or a woman, and it's also true no matter, or across many different types of cancer. But when you look further afield to different parts of the world, you'll see that these same successes are not occurring universally. On the left we have lung cancer, and on the right breast cancer, and you see that there are very large magnitudes of difference between the survival rates with these cancers between different countries. And that has, in many aspects, to do with people's access to the care, the diagnosis, the care, and the medicines they need to treat these cancers. And a big part of the problem is the dogma that's been around for now many years that prevention is better than cure. The top left, you'll see the different types of cancer and their associations with different environmental factors, most prominently tobacco and lung cancer and many other cancers, or cervical cancer and HPV. And absolutely, we should be investing, as public health and global health have, in the things, in interventions to reduce and prevent these types of cancer. But a lot of this advocacy and global health work has missed treatment, has said that we have to focus on prevention, and prevention is incredibly important. I wouldn't have done a Masters of Public Health if I didn't believe that, but it has to be complemented by treatment and cure as well. And in the middle, you can see the US cancer moonshot, which focuses largely on research and almost and very little on intervention and getting these cures that we find to the rest of the to people out there. And in the top right, you'll see the US investment in global health. And you'll see that cancer is not even listed on the different types of diseases, which again is not to say that HIV or tuberculosis are not important, but that we do need to think about how we approach non-communicable diseases in a global setting as well. I was very fortunate during my time at Harvard to study with Professor Paul Farmer, and one of the key lessons from his class was this idea that prevention should not come at the expense of treatment, that if someone comes to you seeking treatment, no matter where you are in the world, that you should be able to provide them with that care and that treatment, and that care has to be front and center of what we do in global health. And in a similar vein, Professor Peter Singer from Princeton, another Australian, has this very famous analogy that says that if you were to be walking along and saw a child drowning in a lake in front of you, that you wouldn't think twice about diving in to rescue that child, even if you had expensive shoes on. But if you heard similarly about that child somewhere out of sight, perhaps in another country, dying of a disease that would cost the same amount as those shoes would to treat, you wouldn't necessarily be willing to give the same amount of money. And that's, I think, a very important principle when we think about cancer. And so there's a movement started by two oncologists, Vishal Gaiwali and Chris Booth, called the Cancer Ground Shot. And that says, well, it's great to go to the moon. It's great to have all this investment in finding the cures to cure the cancers that are currently untreatable. But we also need to spend time, effort, and money trying to get the cures that we know work to the people who can't currently access them. And they've called that a ground shot, the idea that we could save so many lives by increasing the access to the treatments we know work. And so I want to highlight some different categories of cancer drugs to help you understand. You can see here examples of cancer drugs, intravenous on the left and oral on the right, and the number of countries that list them on there as available in their countries. The first group is the group of drugs that have been around for many decades now that are chemotherapy. They're quite cheap to produce. They're very much generic. Most of them are generic, certainly all these ones are generic. But yet you'll see that some of them are still not even available in half of the countries surveyed in this study. The next group are drugs that are a little bit more expensive to produce, monoclonal antibodies, but they're also generic or biosimilar and off patent. And then you can see that, less than a quarter of countries list these drugs. And then these oral drugs, which have become much more prevalent in the last 2 or 3 decades in cancer treatment. And some of these are on patent, some are off patent, but you'll see that the number of countries listing these drugs is available, in some cases, in the single digits. These are all incredibly important cancer drugs. And another key thing to highlight here is that just because a country lists one of these drugs doesn't mean that that drug will actually be available, because more than half of the time, that drug's only available at full cost. That means that the patient has to be able to afford them to pay for the entire medicine themselves. And so I want to flip the narrative a little bit about access to cancer therapies, because often we talk about health literacy and diagnostics, but actually a huge amount of this comes back to money and patents. And I'll go into those in a bit more detail. Of course, manufacturing, supply chain, regulatory delays, and infrastructure are all huge topics that I don't think I'll be able to cover all of those in the 10 minutes I have, but I do want to put some of these on the table as the important barriers that we need to try and overcome. And so Dr. Murray last night highlighted this slide, which was very kind of her, before she even knew I was about to talk about it today, which is to say there have been some incredibly important agreements between manufacturers, drug companies, and the Global Fund around TB and HIV to increase access to medicines and diagnostics in low and middle income countries. And these are the sorts of agreements that we want to work towards in other areas of medicine. And so I want to briefly ask, what can we learn from PEPFAR, the President's Program for AIDS, and the Global Fund that we could take to other areas such as cancer? Well, they've got really strong coalition building and awareness of the importance of this issue. They provide HIV medicines free at the point of care to patients. And I saw this when I was a medical student on elective placement in Tanzania, that patients could access HIV medicines better than any other medicines that we had available. And very importantly, it's a long-term and holistic commitment that they integrate diagnostics, monitoring with the provision of treatment. And we want to achieve something similar with cancer. But another point that often goes under-recognized is this ability to maintain separate markets in high and low and middle income countries. That is, a company like Gilead manages still to earn $5 billion in the last quarter of 2022 at the same time as they're providing their HIV drugs at cost price that are free at point of care in low and middle income countries. So the companies are, I think, scared that their markets in high income countries will be damaged if they agree to different mechanisms to make them available in low and middle income countries. And I think in HIV and in TB, but particularly HIV, that's been done very well. And so here are some of the solutions or some of the ideas that I want to talk about. The first is to say that, much like with infectious diseases, we need a central coordinating mechanism, perhaps a global cancer fund that is able to focus the advocacy and capacity building and the fundraising with the logistics and the long-term commitment that we've seen done to some extent or very successfully in infectious diseases. And let me now talk about some of the other examples. So one positive example is a group called the Max Foundation, and they, over the past 20 years, have built capacity in more than 50 different countries where they've made oral tablets for chronic myeloid leukemia available at the same time as making diagnostics available by working together with companies like Novartis to make those drugs available. And there are other similar partnerships and programs where they have discounts available. And the advantage of this is that you get around the high drug prices and the legal challenges because you're working in collaboration with the pharmaceutical companies. But the current programs only serve a limited population, and you have to find a pharma executive or a diagnostic executive who's willing and who sees the world in the same way and is willing to work with you. Another approach is through voluntary licensing, which is where you work with different coalitions to get an agreement to be able to use the patents or that the companies won't enforce the patents in certain places. And that is done through something called the Medicines Patent Pool. And really the patents are a huge part of this story because companies get very understandably protective of their patents. And so this goes about working with people to try and reach agreements prospectively. And it's great, but it can move slowly and hit speed bumps. Another approach is something called compulsory licensing, which is where a country or a group of countries come along and they say, right, we can't afford to pay the amount of money that you're selling your drug for, but we can either make it ourselves or we can pay someone else to make it for much cheaper. And you'll see that Thailand, India particularly has been a leader in this, managed to reduce prices by more than 90% through these agreements. But unfortunately, they're not much less common than we would like, because high-income countries like the US actually threaten these countries when they pass these regulations through. And in fact, when I did a class at HSPH with the former health minister of Malaysia, he talked about doing this with hepatitis C drugs. And he said that after they passed a compulsory licensing in Malaysia, that was very difficult for Malaysia at the next World Trade Organization, because the US came and really bullied them for having done that. And so I think we need to remove barriers. We need to help many countries operationalize these agreements. And really, and I've given another example in prostate cancer of how much the drug actually costs versus how much it's sold for, that their magnitude, we need to de-link the price from the cost, the amount it's sold for from the amount it's cost to produce. And so I want to come back to you and say that I think the status quo is unacceptable. We have these cures, we have these treatments. It's not as Dr. Murray said yesterday, it's not a scientific problem, it is a humanitarian, and I would add a policy problem. And that's why I'm so passionate that we need to urgently find ways to coordinate, to overcome these barriers that are, as I said, largely legal policy barriers and also financial barriers, to ensure that patients can receive these cures and these treatments that we know work so well all around the world. Thank you so much. Yes, of course.
I'd be interested to hear your take on CAR T cell therapy, specifically because obviously it's very time intensive in terms of preparation of the cells before you re-inject them into the patient. So wondering, in my view, it's something that could replace chemotherapy in the future, but I'd love to hear your perspective.
So as it happens, it's something I do a lot of work on. I guess I would start by saying that in the global context, I wouldn't say the lowest hanging fruit. You know, when you can make an enzalutamide pill for $3, for some context, the CAR T therapies cost $400,000, $500,000, $600,000 in the US. Now, there's some great work, for example, in India, making CAR T for $30,000, but $30,000 is still a long way from $3. And so, absolutely, in an ideal world, I would love those therapies to be to be globally available, and one of the ways to that is through academic institutions making them themselves. But I would say we're still quite a way off. You know, it's amazing work that they're doing, but we're still a way off those therapies being kind of widely accessible, given that there are big access issues in high-income countries for those products. This is the podium mic. I just muted the podium mic, so maybe it's that.
So you're a brilliant cancer researcher and an IT wizard. That's awesome.
You won't use that.
No, it's okay. I don't need it. Any other questions for? Oh, there's one more. Do you mind repeating the question?
Yes.
Turn that one off before you go to the next one. Thank you.
solutions for diseases like, let's just take malaria or TB as an example, low cost effective diagnostics, point of care technologies, medications that are known to be proven effective and available at cost or below cost, and yet we still have a significant disease burden, as also Dr. Megan Marie pointed out yesterday. And so I'm wondering, particularly if we try to transition the idea of global kind of public-private partnership funding models and coalitions to a chronic non-communicable disease or just NCD space in general, in your mind, where are there other parallels or potential ways to learn from the examples in the infectious disease space and apply them to the non-communicable disease space, especially if you're thinking about certain cancers that may be chronic in nature or where it's not quite as simple as, a DOX regimen or an antiviral regimen, where we can also better understand transmission patterns that might be seasonal or where specific target hotspots might be. So just curious if you can kind of play out that example a little bit further. Thank you.
Thanks for the question. To repeat the question, it was basically parallels between infectious and non-communicable diseases in sort of drawing out this global cancer fund idea about what could we learn. And I think in the first instance, it's about taking the lowest hanging fruit. So to say, which are the curable cancers and can we make those therapies available? Hodgkin lymphoma is a good example. Young people, so they've got a lot of productivity left, very cheap drugs, very high cure rates. So really no one should die of Hodgkin lymphoma is a kind of easy thing to say. Similarly, the oral tablets where you take one tablet a day. I think, hearing the models you talked, or the examples you mentioned, straight away to me, things like CML and CLL that are now treatable with a single tablet every day sounds to me a lot like HIV. You have a diagnostic test that is pretty reliable. Sometimes I know it's been a big issue with COVID and TB diagnostics, but piggybacking off GeneXpert diagnostics is another area that we could certainly learn from in cancer medicine. But certainly integrating diagnostic with treatment. And then, I think there are a lot of parallels both with the shorter term, more curable cancers where you could look at how does TB work, very similarly, 6 to 9 months of treatment, sometimes shorter, test for cure, in a kind of similar way, or HIV, and is more analogous to those chronic cancers. But I think there are heaps of lessons, and I think it's a great question.
Thanks, Eddie. And actually, I've been given the sign from David that the next two speakers, if you would like to ask questions, please come afterwards and speak to them just so we can stay within our timeline. I really love the title of the next speaker's talk. It is Apoorva Gomber, and it is Audacious Humanity. Apoorva is a physician. She's trained in global health, and she is currently she's the Associate Advocacy Director for Global Health Equity. Perfect for our conversations this past 2 days at the Brigham and Women's Hospital, and she also graduated with an MPH in 2022. Here you go, Apoorva.
So, hi everybody. Thank you for being here. I want to introduce you first. Oh, sorry. So, my topic is bridging global inequities in caring for people with severe chronic NCDs. And it's a great segue from the topic we just had, from stigma discussions to access to cancer drugs to now going back to the people on the ground. In my day job, I work as the Associate Director of Advocacy, and I'm really passionate for this work, which you'll see in the next slides as well. But I want to take you to a journey of a disconnected world. We live in a very disconnected world, and what determines diabetes outcomes is, like we say in real estate, location, location, location. So these are two images of two girls, 2,700 miles apart, both living with type 1 diabetes. One is in the United States, trying to learn how to inject insulin in a dummy tummy. She opened a refrigerator, took out the insulin, and injected it on a dummy tummy. On the other hand, there's another girl, same age, diagnosed with type 1 diabetes, doesn't have a refrigerator, but had to dig up the ground to take out a bottle where she stored her insulin because the temperatures outside are hot, and that's where she stores it. That's what she has. And these are two images that clearly contrasting show you we live in a disconnected world. And yes, the diabetes outcomes are clearly determined in the place we are born. So these are wide inequities in care. We understand there is huge disparity. Where a child lives should never determine whether a child lives. And yet, more than 95% of children with even sickle cell disease in the United States can survive into adulthood. But in contrast, in low-income countries, that number is less than 5%. This disparity is medically unnecessary as it is unjust. No disease should be treatable in one country and yet a death sentence in another. So we know we have avoidable deaths. Non-communicable diseases today represent the biggest gap in universal health coverage for the poorest billion. Although these diseases have been identified as global health priorities, you would see them in global priority discussions, but they're almost entirely focused on preventable factors, lifestyle-associated factors such as type 2 diabetes, hypertension. This agenda completely excludes the world's poorest and the most vulnerable people who suffer the heaviest burden of unpreventable diseases in the global south. Now, for the world's poorest billion, more than 90% of who live in sub-Saharan Africa and Southeast Asia, severe non-communicable diseases lead to more than 560,000 avoidable deaths among children and young adults each year. And that's more than number of deaths that are caused by HIV, tuberculosis, and maternal causes combined. Now, just 4 conditions: type 1 diabetes, sickle cell disease, rheumatic and congenital heart disease account for as many as 100,000 of these deaths that happen. And these tragedies continue even though cost-effective solutions exist in many of these high-income countries. In some instances, and you must know about it, insulin discovery happened 100 years ago, but still we're talking about access to insulin. The disparities continue to exist in high-income countries, but it's way worse in low-income countries. Now, to address this gap, what is the solution? I have to ask you that. But some of the solutions continue to exist and are great examples. The solution to bring care closest to the people who don't have to travel hundreds of miles to get care. Most of the care for type 1 diabetes, sickle cell, rheumatic heart disease, and congenital is very tertiary care focused. So people don't even reach to a hospital and die just without getting diagnosed. Now, NCDI Poverty Network is a group of network which was formed at Brigham-based Center for Integration Science, the co-secretariat, working closely with partners to implement a model called PEN+, which is an integrated care delivery model now existing in 22 resource-poor countries, and it's delivering care in an integrated manner so that the already overburdened health systems can be redesigned through integrated teams that share infrastructure, often led by mid-level providers, through training them, who could deliver these care in highly constrained health system closer to people. So getting care to the district hospital level. Now, this care model was first developed in rural Rwanda in 2006, and it has been recognized. This has proven to be a great blueprint for redesigning health systems to optimize the infrastructure and clinical talent. Scaling up the treatment for severe non-communicable diseases, especially in rural areas, because it's not just about access to care, it's also about training them how to live with the chronic condition throughout life, and also overcoming the stigma which most of the people live with in low-income countries. The last is bridging the biggest gap in universal health coverage. We will not be able to achieve universal health coverage if we leave the people who live in these communities. So as the Associate Director of Advocacy, I'm leading this effort to mobilize people who are living with these conditions and ensure Pen Plus is accessible, culturally appropriate, socially and financially supported. Question is, why now? Because last year, the African health ministers endorsed this policy to safely curb chronic disease crisis, and they have agreed that Pen Plus would be a successful model of implementation. Yet, current resources are not enough. Less than 100 million, just 0.3% of the global health spending is allocated to non-communicable diseases where these people live. Some of the advocacy efforts have led to the adoption of this strategy, but it's time for implementation. Now, rewinding back to the story I showed you in the beginning was a story of the little girl, Estrella. Now, that image is a 12-year-old girl who I had a chance to meet in Mozambique. She had multiple ulcers in her feet. In November 2022, her mother saw that she was losing all the energy she had. She couldn't walk to her school. She had multiple ulcers in her feet. The little girl in the white shirt, she was feeling fatigued, but the mother took her to the nearest health center, where what she heard was, because of the ulcers, both her feet were about to get amputated, because that's what they knew. It's not getting treated, let's amputate it, without knowing the cause of the ulcers. Now, over the months, Estrella got even more sick, and the mother took her to a nearest district hospital, where they saw the ulcers, and they were like, we have to amputate it in 2 weeks. But she got sicker, and then that's what urged the mother to go to a new center. That was the Pen Plus Center, recently opened up, where she was diagnosed with type 1 diabetes, just weeks before getting both her feet amputated to finally getting correctly diagnosed. Clearly shows we need to do so much better. Now, why this story means a lot to me. Here you would see the little Estrella overwhelmed after a diagnosis, confused about her future, what would it look like. We had a chance to meet with her, along with the partners from JDRF and Hemsley Charitable Trust, who are working on the ground with us to implement this Pen Plus model. She was given the tools for her condition, and that it wasn't just a death sentence. That was a moment of solidarity, where everyone came together to offer help. Now here you would see two people testing blood sugars together. Estrella had never known anyone else with type 1 diabetes. It was me and Aaron Kulowski from JDRF, who both live with type 1 diabetes. She was shocked to learn that people can live into adulthood, because she was silently waiting for her to die. Estrella's grim assumption is not entirely misplaced. Children with type 1 diabetes in rural sub-Saharan Africa often die within a year of diagnosis. I felt the warmth in her fingers. This girl had never smiled, was waiting silently for a death that was imminent. A spark seemed to light within her, and a girl that lost her smile. Finally, she smiled. The radiance of that moment keeps me going. You would see that people with type 1 diabetes can change narratives in their own unique ways. And on the right, in the blue shirt, is Aaron, who is the JDRF CEO, also lives with type 1 diabetes. At the same time, Estrella's plight underscored for me to continuously advocate for greater resources for faster scale-up of Pen Plus. 15 years back, and that's where the stigma comes in, I was hiding behind the stigma, the challenges of type 1 diabetes. I posted a face of a girl on social media who was mocked every day as a teenager, that she would not barely survive beyond 30 years of age. And that face was mine. And I finally got the courage to speak up, being a voice to overcome these social injustices and discrimination people with type 1 diabetes face on a daily basis. It matters to me, but this talk is not about me. It's about all the millions of people who are living with type 1 diabetes and sickle cell and rheumatic heart disease, whose voice has been silenced by the injustices in global health. Take a moment and ask yourself, what does this mean to you, and why does it matter to you? And how can you help when every day children are dying? So people are lost, exhausted, and bringing them good quality care is on us. So irrespective of the geographical location, we have to do better. So today I urge you to be a loud ally, starting right now in your own unique ways. But first, please join us in fixing this world. It is disconnected. Let's do it one smile at a time. Thank you for listening. I'm happy to answer any questions later.
Thank you. It's going to take me a minute to get over the picture of the two girls.
Is it on now?
There you go.
Oh. Lots of technical problems today. All right. So I am going to talk about the right to health care. My talk is focused on the US with the special focus on the immigrant population here. So it's basically a talk on access. So the outline of what I'm going to talk about is, first I will analyze the problem statement for you, then I will delve a little bit into my personal experience that led me down this path, and then speak about the solutions that I have worked on and those that I have thought about. So to set the stage, it's very important to recognize that the US Constitution does not mention right to health care. So it alludes to the right to life. And you could say that there are amendments like the Fifth Amendment, the 14th Amendment, the Civil Rights Act, where mention of equal protections of all persons is mentioned, and maybe that could be extrapolated to healthcare. The term persons is highlighted because that is an all-inclusive term. It includes immigrants, it includes folks who are citizens, it includes everybody. So I think that is absolutely critical in this statement. Moving on, I think you have to contrast that with the global landscape, where both the United Nations Declaration of Human Rights and the World Health Organization Constitution of Human Rights mention healthcare and the right to healthcare as a fundamental right for all human beings. So this contrast is very interesting. And what it translates into, this constitutional gap, translates into anti-healthcare laws in general. And since my talk is focused on immigrants, these are the laws that stand out that are against healthcare access for the immigrant population here. I have listed these various laws, but the one that I'm going to spend time on is the 5-year healthcare bar. And what that basically means that once you immigrate here, it will take you 5 years before you will be eligible for the same healthcare benefits as other folks, which is contradictory to the fact that you have equal protection as a person. So it's also important to understand the underlying reasons of why this is happening. And a lot of it ties back to what has been discussed earlier in this conference and in the previous talks. It's cost. So that is the driving force behind most problems in the healthcare industry, and this is no different. So there have been a lot of publications and news articles around the cost narrative, and these are just some snapshots that I am showing you. And what it all basically means is that even though these laws have been created for cost-cutting reasons, but what also happens is that these cost-cutting measures do not translate into actual positive impact for the populations that we serve, which are the patients. They are instead being diverted elsewhere. So that now that we understand sort of the problem, I just wanted to explain how I ended up working on this. So a little bit of what happened was that my father was a recent legal immigrant to this country and unfortunately developed some medical issues. And that was when I realized that there was something called the 5-year bar. So we had to wait 5 years for some of the health benefits that he needed. So this limited insurance then translates into limited reimbursement, which basically translates into possibly inadequate care, all centered on the narrative of cost of care, as I mentioned earlier. Now, what do we do about this? And what I am going to discuss is a little bit of what I have done and also my overall understanding of the problem. My work has been more around healthcare advocacy, but I also have thought significantly about the infrastructure issue that feeds into this problem. So starting with, since I mentioned the 5-year bar, what I discovered after I looked into this matter a bit more is that there is already legislation out there to repeal this, which is called the Lift the Bar Act. Now, legislative process in the US, as in any other country, it takes a while and is quite an effort. So how do you become a player in this change? So for me, the key word became mobilize. You mobilize for change by engaging with lawmakers, you mobilize for change by engaging with the community, and you organize collaboratively, because that is how you bring about change. Now, what I have done across the board on these specific items is that I have personally engaged with several lawmakers, congresspeople, senators, specifically talking about this act. I also mentioned collaboration is very key in advocacy, and I have worked with different coalitions, and the one that I will mention is the HEAL Coalition, which specifically works on immigrant health care. It includes Lift the Bar, but other aspects of immigrant health care as well. And they do a phenomenal job of bringing together diverse organizations to organize around this particular cause. Now, you can have a lot of organizations and individuals working, but you really need a village to bring about change in the legislative stage. So what I also realized that a critical piece was educating the community to join in this cause. And I have done that by working with different lobbyists and coordinating health advocacy trainings where I bring more the healthcare perspective. Since I am not a trained lobbyist, but I have an interest in this, and I really can speak to the healthcare matters. And also created a toolkit for advocacy as well. And of course, as mentioned, I've worked with the whole HEAL Coalition to some extent as well. So this was like my personal foray in this area. Now, that was the health advocacy piece, but that is only a piece of the problem. So I did mention the infrastructure that feeds into this issue. So that is a multifactorial problem, and this is simply a snapshot of my own understanding. And what I realized that one of the things that is really needed is oversight of the hospitals to shift the narrative to the patient from the cost. So bring back the nonprofit. So that was one key element that I thought was extremely critical. The other thing I noticed is that we have patient advocacy in hospitals, which is great. But the issue is that they are working for the same institution while trying to advocate for the other side. It is only human that there would be a conflict due to that. So there should be more of an independent body that acts as patient advocates, especially for immigrant populations where there are linguistic barriers, where there are cultural barriers, and a lot of miscommunication is bound to occur. And then the other thing